Good evening. Thank you so much for joining in for today's session. We'll just wait for a few more minutes for the rest of the participants and for Doctor to join in as well. Good evening, Doctor. You're on mute, Doctor.
Yes.
Hello, good evening.
Hello, good evening. Good evening. So my audio is clear?
Hanji, it is clear.
Fine. So can I
So-
see my slides? Let me share the screen.
Hanji, I've
Okay.
given you the access.
So can you see the slides?
Hanji, Doctor. The slides can be seen.
Okay. Let me see if they are changing also. Yes, they are changing also, no?
Hanji, they're changing.
Chalo.
So we'll just wait for a few minutes for the rest of the participants to join in, and then we can start. Hanji.
Sure. So the meeting is going to be recorded. Are you going to record the meeting?
It is being recorded, Doctor.
Okay. Fine.
Hanji. Good evening, everyone. Thank you so much for joining in the session. We'll just wait for a few more minutes and then we'll start with the webinar.
Video
Doctor, I think we can start, and the rest of the participants can keep on joining in.
Sure. You can start.
Hanji. Hanji,
Yeah.
sir. Good evening, everyone. Thank you so much for joining in the session. Today with us, we have Dr. Sandeep Suri, who's a renowned diabetologist. And today he'll be explaining to us how better we can take care of our medicines that we take in case of diabetes, or the insulin that we are taking, so that uh, we have a better result in our body and a better control over the sugar levels. So those basic small things that we often tend to forget or we do not know, but here doctor will be explaining those details to us so that we get the maximum health benefits from them. So over to you, doctor.
Yeah. So very good evening to my dear friends, all of you who have logged in. And at the outset, I must thank Zaila for the given opportunity to me for this social media platform to interact with my fellow colleagues. And the most important part, that I am interacting with my patients. A very warm welcome to all of you, those who have logged in. So we are going to talk about how to make oral anti-diabetic drugs and insulin work more effectively, with the goal to get better and better sugar controls. And that's how, by getting good glycemic control, what do you mean better and better blood sugar control? What will happen if you get good glycemic control? Actually, you can prevent or delay the complications. And that's why we treat diabetes. That's why we treat diabetes, only to prevent its complications. It is not only the number कि आपका शुगर ज्यादा आ गया, आपका शुगर बढ़ गया, कम हो गया, 200 हो गया, 250 हो गया. Doesn't mean anything until unless you realize that this much amount of sugars, this much amount of blood sugar can lead to lot many complications. And what do you mean by complications? I mean, there can be microvascular complication. That means small vessels, small blood supplying arteries, arterioles can be picked up by high blood sugars. Like that happens in your retina, that happens in your nerves, that happens at your kidneys. So that is retinopathy, nephropathy, neuropathy. These are microvascular complications. Whereas you can have larger arteries, middle-sized arteries, blood vessels being picked up as a macrovascular disease. No, so macrovascular complication can be cardiovascular disease or coronary artery disease, or you can say heart attack, and then there can be stroke, then there can be peripheral artery disease. So to treat diabetes, we have four main pillars. We all try to treat diabetes by making these all four pillars stronger and stronger. And what are those four pillars which are very important? One is diet, lifestyle modification, exercise, and physical activity. This is one thing that is known as comprehensive management of lifestyle modifications. Secondly, drugs, dawaiyan. There can be oral glucose lowering drugs, there can be insulin. Third is monitoring, that you have to check your blood sugars by routine blood sugar testing, glucometer testing at home. Fourth, which is very much important, and it is sometimes it can be missed in many time. Patient will be saying that I am okay, I am taking medication, I am doing some sort of exercise also, I am following the diet, then why should I visit the doctor? So fourth one is very important, that is follow up. Until unless you go to your physician or healthcare physician for your routine checkup, you will not be able to know whether you are under control, whether you are over controlled, or whether you are not in control. So to look at the values of blood sugars which are there, you have to go to your doctor who can interpret all these reports, who can modify your treatment. Because diabetes is not a straight road, it is always a zigzag pathway. Sometimes you have to go up, sometimes you have to go down, sometimes you have to decrease the dose, you have to increase the dose, you have to modify the therapy at each and every turnabout. So it's not a straightforward road, it is a zigzag pathway, haphazard pathway. You have to take care at each and every step. So you have to follow your doctor's advice, and you have to regularly visit to your doctors. So in our busy schedule, in our OPDs, sometimes we may not be able to tell our patients or teach our patients regarding how to take oral anti-diabetic drugs, कब लेना चाहिए, कैसे लेना चाहिए, कितना गैप होना चाहिए मील्स के साथ, खाने के साथ कितना गैप्स होना चाहिए, when to take, how to take. Okay, so and which type of drugs or which type of insulins they are using, when to take insulins, what is the difference between insulin and the meals. And there are so many formulations that it is very tough to remember. So the basic concept has to be told to the patient that this type of insulin or this type of drug has to be taken before meal, after meal. So all these things, they look very small, very small and simple, but may have a great impact in patients management of glycemia. They sometimes you are taking insulin which is has to be taken 30 minutes or 40 minutes before the meal, and you are taking just before the meal, and it is not working. Either it is going to have hyperglycemia post meal, then there can be hypoglycemia. So erratic control will be there until unless you match insulin with your diet, with the time frame. So what is diabetes? First of all, let's learn what is diabetes. So let me move with the slides. Yes, diabetes is a metabolic disorder. It is characterized by high levels of glucose in the blood, and the risk factors are 90% diabetes cases in India are due to change in lifestyle. It is due to obesity and family history. So in simpler term, you can say it is a metabolic disorder which is characterized by high blood sugar value. Now, why it is happening in India, it is, or all over the world, why it is increasing in prevalence and incidence of diabetes? Diabetes per se, type 2 diabetes is 90% environment driven. And there is a lot of changes which has happened in last 20, 25 years or 30 years in our environment. By environment, I mean your health status, your economic status, your accessibility to high calorie food, your easily availability of food, and food is now abundance, luxury is in abundance, sedentarism is abundant. You are not going out for physical activity, you are not going doing least and least work at your home. More or more of us are wanting desk job, or we are, that's why we are having increased insulin resistance, and also there is obesity. So lot many things has happened in our environment. So type 2 diabetes is basically driven 90% by your environment, 10% it is due to your genetics. So the our environment, our lifestyle changes that have clearly changed the whole scenario. Look at your diet, which we were taking 30 years or 40 years, 35 years back. That was much more fiber diet, much more crude diet. Now we are consuming much more refined diet, more refined carbs. We are taking more fast food, junk food, calorie dense food. So, and that is in abundance. You can just put and you can use an app, and just you can call the Swiggies and Zomatos. They will come up with all type of junk food at your doorstep. So the things are very much available to you. So just with a call of a single call, you can get these things available to you right at your doorstep. So things have changed. Things have changed, really changed. You have become more affluent, more sedentary. So that's why you are paying the cost of metabolic diseases. Now, how does diabetes happens? So, so how does this happen? When you have diabetes, your body does not make enough amount of insulin or does not use insulin well. The body is made up of many cells, and each cell needs sugar, glucose for energy. Now, glucose, which comes from food you eat. So insulin is the key that allows glucose to get into the cells to make energy, and insulin is made in your pancreas. So what does this all mean? Diabetes happens, it is due to lack of insulin. Either it is absolute lack of insulin, that means no insulin is produced by your pancreas, or specifically beta cells of pancreas. That happens in type 1 diabetes. That happens in they depend upon insulin for whole of their life. Or it is relative insulin insufficiency or deficiency. That means body is producing insulin, or precisely your beta cells are producing insulin, but that is not working due to insulin resistance at the level of peripheral tissues. And by means, what do you mean by peripheral tissue? It is your muscles, it is your adipose tissue, and it is your liver, which are basically consuming blood sugars. That is maximum consumption of sugars is done by this, and that is already that all depends upon the insulin level. So insulin, if it's not working, blood sugar will remain high, but still your cells will not be able to use this blood sugars for their energy production. In those who have normal blood sugar, or you can say normal glucose tolerance, as has been depicted in this slide, so in patient with in this normal glucose tolerance, glucose in your blood comes from the food you eat. So the foods is the maximum, is the major source of glucose. Number one is insulin lets the glucose go into the cell. That means insulin is the chabi. It is a key which opens the door and glucose enters into the cells. Once glucose enters into the cells of your tissues, of your organs, glucose is then consumed as a source of energy. So it's the most preferred source of energy by the cells or different tissues. But what happens in diabetic patient? Due to either loss or inefficacy of insulin, various tissue in the body are unable to use insulin, or sorry, unable to use the glucose. So despite you are having high blood glucose value, your organs, your cells are not able to use this glucose as a source of energy. So for mostly then what happens, the organs or tissues, they starts using non-conventional or alternate source of energy. And alternate source of energy is coming from lipolysis, that is breakdown of fat, and proteolysis, that is breakdown of proteins. And also by producing glucose from the liver by itself, that is known as glycogenolysis and gluconeogenesis, that all further lead to increased blood sugar level, increased blood glucose pool in the body. And this increased blood glucose pool in the body, that leads to tissue damage and all micro and macrovascular complications. So this happens in a diabetic patient. Your insulin is ineffective or it is not produced. So the glucose which is there in the blood, however, may be the higher level, but it cannot enter in the cells. So cells are deprived of glucose. Now, when a physician, or you can say uh, when you go to your physician or healthcare physician or doctor or a consultant, we are being prescribed either oral anti-diabetic drugs or injectable anti-diabetic drugs, or many times both oral and injectable drugs has been given to the patients. Now first let's talk about the oral anti-diabetic drugs. There are 9 major classes of oral anti-diabetic drugs which we are using, and last, if you say bile acid sequestrants and dopamine agonists, they are not in much of uses. So we will concentrate first 7 classes: sulfonylureas, bigonides, thiazolidinediones, alpha glucosidase inhibitors, meglitide, DPP4 inhibitors, and SGLT2 inhibitors. You need not to know these classes. For the patients, you need not to know the classes. You just remember the trade name which we are writing most of the time. So first, look at the class sulfonylureas bigonides. So they are the most commonly prescribed drugs. Most commonly prescribed prescription is a combination of SUs and bigonides. Now, sulfonylureas, these are the medication which lower blood glucose level by causing the pancreas to release more insulin. They act on your pancreas. They act on the factory of insulin production, that is beta cells of pancreas. And the most common names or brand name which we use are either glipizide or glucotrol XL, or glimepiride, Emeril, Glador, Glinase, Glizid, Dimicron XR, or you can say Reclimat XR. So these are the common glimepiride or glycoside. These are the most commonly prescribed sulfonylureas. Whereas bigonides, these are the medication, they reduce how much glucose the liver is produced. I told you that liver starts producing glucose as a form of glycogenolysis and gluconeogenesis. So this molecule, this class of drug, they try to decrease hepatic glucose output. It also improves insulin work in the body. They decrease insulin resistance also. I told you that insulin is being produced by the body, but it is not acting at the peripheral tissue. So metformin tries to make more efficacy, more efficiency towards insulin action. And it also slows down the conversion of carbohydrate into sugar. So it has got it has got so many multiple actions, and it is a most beneficial drug which we are using with the least amount of side effect. And the most common brand name which we are using are like glucophage XR, Glumtaz, or Fortamet, Riomet, or Gluformini, or you can say glycomet or xmet xr or sustained release. Most of the time, if you look at the dosage, glimepiride is being used in the form of 1 milligram to 4 milligram. Glyclazide is being used in the format of 40 milligram or 80 milligram. Or if you are using extended release XR, then you are using 30 milligram or 60 milligram. Whereas metformin is being used in the format of 500 milligram or 1000 milligram. So we try to get the dosage of metformin up to 2000 milligram per day, and maximal use of sulfonylureas is up to 4 milligram per day, or up to 4 to 6 milligram per day for glimepiride, and up to 180 to 320 milligram for uh, glyclazide. So that's how we try to slowly we start slow and we try to build up to the dosage, and as per the recommended doses we go up to the recommended doses as I have told you regarding sulfonylureas and metformin. Now, how to take sulfonylureas? If you are using if you are taking sulfonylureas or Glador, or you can say Amaryl, has to be taken 20 minutes before the meal. So this is important that you have to take 20 to 30 minutes before the major meal. Now, how to take metformin? Most of the time we are using sustained release, extended release, or uh, 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 sustained release metformin. They can be taken at any time, or if you are using plain metformin that is there in many combination, then you have to take it after the meal, because metformin per se has got metallic taste. It can lead to bloating, it can lead to nausea also. So most of the time we take it after the meal. And sometimes patient comes, very interesting thing that happens, that patient comes to us that डॉक्टर साहब जो मैंने दवाई मेटफॉर्मिन की गोली या आप जो गोली देते हो दो रंग वाली, because two color means we are using a combination of drug like sulfonylureas, metformin are being used in a combination, so the drug is two colored. It's a bi-layered, two color, different colors of the molecules is there. So जो drug दवाई आप देते हो सुबह मुझे, वो as such लेटरिन में और स्टूल्स में पास हो जाती है, गोली एज सच निकल आती है, या समटाइम आई डू हैव वोमिटिंग, देन दिस ड्रग कम्स आउट एज सच. एक्चुअली दिस इज नोन एज ए फैंटम टेबलेट. इसमें जो मॉलिक्यूल है, जो दवाई है, वो वैक्स का अंदर फैंटम टेबलेट होता है. इट इज आइदर hot mix technology or a waxed complex technology is being used to make it a standard or to make it as a sustained release or make it as an extended release molecule. So that molecule, that vehicle, or that wax coated molecule, drug shaped thing, that remains as such. The molecule or the drug which was there, that has diffused already into the blood circulation, so that remains, and that comes out in the stool or comes out with the vomiting. So it's a phantom drug, it is a phantom tablet which is there, so need not to worry at that time. So remember that you have to take sulfonylureas 20 minutes before the meal, whereas you have to take metformin 30 minutes after the meal. But if you are using combination therapy and you are using extended release or sustained release molecule of combination of sulfonylureas and metformin like glycomet GP24, GP14, or uh, dimicron XR for diamomet XR like, or reclimet XR4. So these are the molecule which can be taken as such 20 minutes before the meal. Then metformin doesn't lead to these side effect of gastrointestinal side effects are not there. So you can take these molecules 20 minutes before the meal. Now, what about thiazidolidones? These are the drugs, these are the medication. They improve the way insulin work in the body. So again, you have insulin sensitizers. Bigonides are insulin sensitizers. These TZDs are again insulin sensitizers. They improve, they make the insulin more efficacious. They improve the way insulin works in the body by allowing more glucose to enter into the muscles, fat, and the liver. So the drug which we use brand is pioglitazone, and we use as a Pios 7.5 or Pios 15 milligram. And sometimes it is there in the combination, triple drug combination is already there, or sometimes we use this molecule as a solitary molecule and isolated molecule along with the combination of sulfonylureas and metformin. This can be given at any time of the day. at any time of the day. But if I say you can take it any time of the day, try to fix the timing of that molecule. Try to fix the timing of that dose drug. Irrespective of the meal, you take it any time of the day. Maybe it convenient time is 10 a.m. or it is 8 p.m. But try to fix the time of the molecule. Try to fix the dose time of that drug to make it more efficacious. Another thing to remember it that these TZDs molecule, they take some time to get to reach their proper efficacy. So the effect that comes where TZDs comes are after 3 weeks. So you have to be patient. You have to take this molecule up to 3 to 4 weeks, up to 1 month. You have to wait for their proper efficacious, proper results in blood sugar lowering. So you have to wait for 3 weeks to get its proper efficacy. Now about alpha glucosidase inhibitors, it's a very good drugs. They decrease postprandial excursions. These medications lower blood sugar levels by delaying the breakdown of carbohydrates and reducing glucose absorption in the small intestine. They also block certain enzymes in order to slow down the digestion of some starches. So they are the good drugs to decrease postprandial excursion. खाना खाने के बाद जो sugar बढ़ता है उसको कम करने के लिए these molecules are being used. Now the brand name or the drugs which acarbose, maglitol or voglibose. Acarbose, or you can say glucobay, is being used in the format of 25 milligram TDS dose or 50 milligram TDS dose, or whereas voglibose commonly used in the format of 0.2 milligram TDS dose 3 times or 0.3 milligram TDS dose. Now important thing is that these are the molecule which are taking care of postprandial excursion. They have to be there in the intestine before your major meal comes. So either you chew this one tablet of acarbose or glucobay with the first bite. Most of the time I tell my patient कि रोटी का पहले टुकड़े में आप इस गोली को डालिए, इस गोली को फंसाइए और उसको सब्जी के साथ लगा के चबा लीजिए पहले टुकड़े के साथ. Or you have to take it 20 minutes before the meal for their proper efficacy. So you have to remember this, that these class of molecule has to be taken 20 minutes before the meal or chew with the first bite of the meal. Secondly, maglitide. These are the also molecule which take care of postprandial excursion. They are just like sulfonylureas, but they are non-sulfonylureas glucose lowering drug. They act also on beta cells of pancreas. These medication lower blood sugar levels by getting the pancreas to release more insulin, just like sulfonylureas, but they have got their different receptors, and they are shorter acting drugs with lesser hypoglycemia. So we use Novonorm 0.5 or 1 milligram repaglinide, or Urepa 0.5 or 1 milligram repaglinide, or that sometimes it comes in a combination with voglibose also. And this drug has to be given 20 minutes before the meal. If you are not using the meal, then this drug should not be given. So one meal, one drug should be there, and it has to be taken 20 minutes before the meal. Now coming to DPP-4 inhibitors, these are very commonly used molecules. So these medications are very good drugs because of their least chances of hypoglycemia. They are very safe, very efficacious drug, and they help your pancreas to release more insulin after the meal. They also lower the amount of glucose released by the liver. So both fasting glycemia and postprandial glycemia are being reduced by DPP-4 inhibitors. We are using these brands as a sitagliptin, saxagliptin, linagliptin, alogliptin, and vildagliptin. And there are so many brands, trade names are there: Januvia, Onglyza, Trajanta, Nesina, and then there is Galvus or Jalra is there, and they are being used in a combination with metformin. Most of the time we use them in a combination with metformin. Now, how to use DPP-4 inhibitors? DPP-4 inhibitors should be taken 20 minutes before the meal. And if you are using OD dose like saxagliptin and linagliptin and tenligliptin, they are being used as an OD dose. Try to fix the time of the drug. Try to fix the time of the day for OD doses. So to make it a proper pharmacokinetic profile should be maintained. So, or you have to take it 20 minutes before the meal. Then what about SGLT2 inhibitors? Again, these molecules are being used in a big way because they reduce weight also. They are leading to glucosuria. They try to reduce weight try to decrease your waist hip ratio, also decreases blood pressure. So many cardiovascular benefits, so many renal benefits has been there. These drugs, they work on your kidneys to remove extra sugar from your body. So and the molecules which we are using, canagliflozin as a Invokana or Sulicent, dapagliflozin as Forxiga, empagliflozin as Jardiance. So these are the molecules which you are using as an monotherapy or in a combination with DPP4 inhibitors or in combination with metformin. So it's a big way we are using these molecules. So most of the time, if you are using OD dose of these molecules, then they have to be given in the morning, because uh, uh, and for canagliflozin specifically, it has to be taken before meal. Otherwise, for Forxiga or dapagliflozin or empagliflozin, they can be taken at any time, irrespective of the meal. But mostly we give it with the breakfast. And importantly, when you are using this molecule, you must remember that you can have 1, 2, or 3 times more urination, because they, as the drug work on the kidney and they remove extra sugar from the body in the format of urine sugar levels. So urine sugar will be increased, because the body, these drugs try to excrete sugars in the urine. So you will have 1, 2, or sometimes 3 times more urination. So you have to take care of your hydration status. Most importantly, especially in hot and humid environment, you have to take care of your hydration status. And once you go for the blood sugar levels and urine examination in your lab, you must remember that your urine sugar will be 3 plus or 4 plus. That only indicates that your drug is working. It is not to worry that your sugar is on a higher side. Another thing, there are certain side effects or adverse events can be there, like belnoposthitis in males, vulvovaginitis in females. So importantly, you must learn about the genital hygiene from your doctor once you are using SGLT2 inhibitor molecule. Now, importantly, you must tell your doctor or healthcare physician once you go to fasting, like Ramadan fasting, Navratra fasting, or Jain fasting. If you are going to have religious fast, you must ask your doctor whether you are fit to have these fastings, or how can you modify the therapy. So it has to be done pre-hand, at least say for longer duration of fast, say Ramadan fasting that has nowadays it is going on. So 1 month back, you have to get into the schedule of fasting. Then again for Navratra, at least 1 week earlier to Navratras fasting, you have to tell your doctor that try to, if I am taking these medication, I am having this much amount of blood sugar levels, this much is my comorbidities, whether how should change, whether I can go for fasting, then how to change these molecules, how to change my drug therapy according to my fasting levels, fasting in the period. Also, if you are going to change drastically in your diet, like you are following keto diets, or you are going to have some certain ayurvedic medication, weight lowering medication, or herbal medication, please let your healthcare physician to know about these things which you are doing. Don't keep it under the table, don't keep it under the carpet. Otherwise you will have, and you can have any inadvertent event, or you can have any issues which can be unexplained. You can even damage your kidneys, liver, or there can be lot many interaction with the allopathic medication. So always be in a fine tuning with your healthcare physician. Always tell him that I am taking these medication, whether it is allowed or not. Now moving to insulins, uh, moving to insulin, uh, there are two type of insulin which we are using. Either it is a bolus format or a basal format. So bolus format, that takes care of your mealtime insulin, meantime blood sugar levels. So for bolus is rapid acting insulin. It is Aspart, Novolog, Novorapid. Rapid acting insulin can be Epidra or Glulysin, or it can be Lispro or Humalog, or it can be short acting regular human insulin in the form of vial or pen pills or devices. Then there can be basal insulin, which is intermediate acting. That means you have to give it in 2 times a day, NPH insulin, or you have to take it intermediate acting in the form of Lente. Lente is not available, so NPH is most commonly used. And also then ultra long acting insulins are there, like Degludec insulin and Tuzio insulin, and Glargine is long acting insulin, which is already there. So there are various type of insulins which are there, depending upon their onset of action, peak effect, and their duration of action. Basically, one type of insulin, they take care of your mealtime blood sugar release or meantime blood sugar control, and another type, that is basal insulin, that gives you 24-hour control. So these are the two type of insulin which we are using, and many times it is in the format of pre-mixed insulin. So it's already in the format of combination insulin. So combination can be it can be 30-70 of human mixed-start, or a rapid acting short acting insulin, or a with intermediate acting insulin. So there can be human mixed-start, or it can be an analog insulin, no mix 30, or it can be humalog mix 25-75, depending. It can be an analog insulin. So this 25-75 or 30-75, 30-70, it basically indicates how much amount of bolus insulin is there and how much amount of basal insulin. If they are in equal half, it is 50-50, or if it is 30% regular acting and 70% basal acting insulin, then it is 30-70. If it is reverse, like 30-70% is short acting or analog insulin, fast acting or rapid acting insulin, it is 70%, or 30% is long acting insulin. So most of time in India, it is available as a 30-70 or a 50-50. So the onset of action depends upon the bolus component of that mixture. It is if you see that how much is the bolus component acting, it is onset of action is around, if you are using regular insulin, it is 30 to 60 minutes. So for regular insulin, or you are using pre-mix insulin, because onset of action depend upon the short acting or rapid acting insulin. If you are using analog insulin, it has to be taken 15 to 20 minutes before the meal. And if you are using human mixed start, or a regular human insulin plus no NPH insulin in a 30-70 mixture, it's a premix insulin, then it has to be taken 30 to 40 minutes before the meal, because this much time is required to get conversion of insulin from hexamer to monomer. And for absorption of insulin into your blood, it has to be converted into monomers. So this is the onset of action. Then the peak effect comes, and peak effect is also dependent upon your regular or short acting insulin. Around 2 to 3 hours it takes, or if analog insulin, it is 1 to 3 hours it has to be there. And duration of action is also depending upon the type of insulin you are using. Now for premix insulin, it has to be taken, if you are using premix mixed-start insulin, human mixed-start, which is very commonly used, most commonly prescribed insulin is human mixed-start insulin, 30-70, it has to be taken 30 to 40 minutes before the meal. If you are using analog insulin premix, like Nomix 30 or Humalog 25-75 or Iglucent 25-75, it has to be taken 15 to 20 minutes before the meal. Sometimes we are using fast insulin, that is very fast acting, or you can say rapid acting insulin. It's ultra fast acting insulin. It has to be taken 5 minutes before the meal, or even up to 10 minutes after the meal, or it can be taken even in between the meal. Whereas Nomix 30 or Novo Rapid has to be taken 15 to 20 minutes before the meal, or even 10 minutes after the meal can be taken, but the best is 15 to 20 minutes before the meal. So this thing has to be remembered in your mind once you are using insulin, that what time insulin should be taken comparative to the time of your meal, because you have to take insulin peaking should be there once your blood sugar peaking from the meal is there. So you have to mirror it, just the peaking of insulin and the peaking of your blood glycemia has to be at clear cut same time, or at a same interaction time, so that to decrease this postprandial rise in blood sugar level after the meal. So time is exactly, it's extremely important once you are using insulin. Now, how to store insulin? So remember that always store insulin in refrigerator. This is one line you have to remember. So if you are using insulin, should we purchase refrigerator? I will tell you various alternatives. No, you should not purchase refrigerator. So you can have many alternative things. So, but remember that the dictum is that if you have got refrigerator, the insulin has to be stored in refrigerator, new and old one, but don't freeze. Don't put it into direct ice. Don't put it into freezer. You have to put the vial or pen fills which you are not using or using into the door basket of the refrigerator, where you keep your butter or you bread or some side window of the door of the refrigerator, not into the freezer. So remember that, do not freeze it. You have to protect insulin from the sunlight, because it's a protein molecule. Direct sunlight, direct heat can make it disintegrated, and you can have precipitation. So protect it from the sunlight. If you are not having any uh, refrigerator, you need not to worry. You can have insulin into put that insulin into some earthen pot, like you can have surahis, kasora, or bowls with cold water that can be put into that container, and you can have insulin vials or pen fill can be put into that thing, and you cover it, and you place that thing into dark place or a cooler place in the kitchen or somewhere in the living room. You can have that thing there. So need not to put into a refrigerator. Actually, the unopened or fresh cartridges or fresh vials which are there, they have to be kept into the refrigerator with the or you can say unopened vials or canisters has to be put into the refrigerator. And they say that temperature maintenance should be between 2 to 8 degrees centigrade. Do not freeze them. Otherwise, if you are using the pen fill, or if you are using the pen, or if you are using the vial that is in use or opened, it has to be there in the temperature not more than 30 degree. So 25 to 30 degree temperature, they can be kept at even room temperature also. But this cannot be applied to our scenario, because we have got, in summers your temperature can go to even up to 40 degree, 45 or 47 degree, very high temperature can be there. So these remember that you have to keep insulins, whether you are using it or not using it, into the earthen pot or surahi kasora type of thing, and into the dark place, cooler place. Never let it go beyond 30 degree temperature, because beyond 30 degree temperature, the protein molecules, protein structure in the insulin, they get starts unfolding. There can be degradation and precipitation. And once you, if suppose, and before using insulin, look at the vial or the pen fill, that is the, and look for the precipitation. There should not be any clots or clumping should not be there. If that is there, that means your insulin is more than 5% disintegrated. So that insulin is basically spoiled insulin. You have to throw that insulin and take a new vial, or take a new pen fill for that. That requires a replacement. So that is a spoiled insulin. If there is a clumps, don't never to use that thing. Also, there are two things. One is expiry date of insulin, and another is date of usage. Expiry date of insulin, which is written on the vial or the pen fill, it is sometime 2 years or 3 years. But but we say that you discard after 28 days. That is the date of usage. The remember that once you start using this insulin, you write down the date on the vial or the pen fill by say permanent marker or somewhere. Suppose you are using this insulin today. Today is 20th. 20th is the date. 20th April is the date. Then this molecule, this insulin can be used up to 28 days, or up to maximum up to 30 days, if you take it between 2 to 8 degree or less than 30 degree temperature, if you are maintaining it. So this insulin can be used up to 28 or 30 days maximally. And if it is left there in the vial or in the canister, you have to remove it, you have to throw it and take the newer one. But sometimes it is somewhat controversial, and some data is there that you can even take up to 5-10 days more, because only 1% or 1 to 3% damage is there in the insulin. So there can be cost involved in that thing. So sometimes we say that you can, if there is a cost strain or lockdown situation is there, sometimes I tell my patient, you take higher dose, 3% higher dose of that insulin even after 28 days. But the recommendation is that after usage of 28 to 30 days, you have to discard that vial or the pen fill, take a new vial or the pen fill. Never put your insulin pens or vial on the in the locked car, or on the stabilizers, or over the top of the TV, or over the top of the fridge, because even for the few seconds or few minutes, if you place insulin or pen fill over that areas which I have told you, they are extremely hot, near oven, in the kitchen, they are extremely hot areas, and insulin can be degraded very within few minutes or within few hours if insulin is left like that. So it will degrade at right at that point. So that will be spoiled insulin. So never to put insulin at these areas that I have told you. Now, when buying insulin, confirm that it was stored in refrigerator only. So this you have to take कि आपका केमिस्ट कहाँ से इंसुलिन निकाल के दे रहा है, कहाँ से दे रहा है, उसके पास कोल्ड चेन मेंटेन हो रहा है कि नहीं हो रहा, whether he is having refrigerator or not, whether he is having generator for that refrigerator or not, round the clock 24-hour electricity is available or not. So this is how you can check the efficiency of the your chemist, and you can say that the chemist who is having cold chain maintain is giving you exact insulin which you require. Now, to how to use insulin correctly. So remove from the fridge 10 to 15 minutes before injecting to avoid the fridge cold insulin, because if you inject cold insulin, it will cause more pain. Gently rub insulin pen between your palm in case of premix insulin to avoid shaking. Don't try to shake like that. You have to rub it, roll it 20 times backward, forward. It is one time. So 20 times like that. Or the while is that, then you have to do it like that. So this is how you have to gently rub it. In case of long acting or short acting insulin, no rubbing is required between the palm is needed. And if you are using premix insulin, whether you are using premix human insulin or analog insulin, they require rubbing, or you can say they require mixing with each by rolling in the palm. So this is very important. Secondly, how to inject it correctly. So pinch the skin at 1 or 2 inch portion of the skin, and in between your two finger and your thumb, between your two finger and the thumb, or best is between one finger, first finger, and the thumb, just as has been shown in this diagram. Now, pinching is sometime if you are obese or normal weight person, pinching is not required. Pinching is definitely required to give insulin subcutaneously if you are injecting in a childhood diabetic patient, type 1 diabetic patients, or elderly patients who have got very low lean body mass and thin subcutaneous tissue. Then you have to pick up, or you pinch it up. The subcutaneous tissue has to be pinched up. Now, inject at 90 degree if patient is normal weight or obese weight. Inject at 60 or 45 degree if patient is childhood patient or lean thin patient. Then you have to inject at some angle, that is 45 to 60 degree angle. Or best is if you are normal weight patient or obese patient, overweight patient, then inject directly at 90 degrees, straight, smooth prick. It has to be gone. You have to go very smoothly inside in a single go, never to jab it, never to push it, but go very smoothly. Keep in the same place for 10 seconds after injecting insulin to avoid any leakage. Now, it's very important. Many times patient inject insulin and comes out directly. So it should not be done. It should be, you should wait for at least 10 seconds before after injecting insulin. So to avoid any leakage. Now, how to calculate 10 seconds? So what I tell my patient, after injecting the dose, you stay there and calculate 101, 102, 103, 104, 105, 106, 107, 108, 109, 110. Now come out smoothly. So this is how you take 10 seconds. But if you are obese patient, morbidly obese patient, very thick skin, then you can even have to calculate up to 115 or even up to 120 also. That means 15 or even 20-second wait has to be given. Again, very important, change the site of injecting insulin to avoid getting hurt, and inform doctor in case of any issue. Change of site is very important. And if you don't rotate the site of insulin injection, there will be a fibrofatty tissue that will be at the thickened tissue that will be there at the site of insulin injection, which is you are injecting repeatedly at same site, you will have lipohypertrophy. And this is the most common reason when you say that doctor mera insulin ab kaam nahi kar raha, because you are injecting at a same site at every time. So this is lipohypertrophy. Our problem is that in lipohypertrophy site, there is large amount of fibrous tissue and fatty tissue with less vascular supply and less nerve supply. So patient will feel lesser pain, keep on injecting there, and it will be lesser absorbed because of lesser blood supply, and there will be erratic absorption from lipohypertrophy. Sometimes you will have hyperglycemia and sometimes you will have hypoglycemia. So there will be erratic swings in blood sugar values if you take injection at lipohypertrophic site. So remember that rotation of site is again very important. Now another important thing is that you have to change the insulin needle also, injection needle also. Sometimes patient continue using insulin needle because patient has never been told that this insulin needle has to be changed. Now when to change insulin needle? Actually the protocol is that with every injection you have to change the needle, but cost is the biggest barrier. So I tell my patient after second day, that means if you are using premix insulin, one day gone, second day gone, that means 4 insulin injection has been given. Now by fifth dose you have to change the needle, even if it is not paining you, even if it is not doing any harm to you, you have to change the needle. So by changing the needle, changing the site, so rotating the site, waiting for 10 to 15 seconds, so you can have better control with a similar dose or even lesser dose of insulin. And this is the most common sites we ask for the insulin injection depending upon their better and better absorption. It is best is around the umbilicus, forefinger on the both side. This is the that you can see here that the marking is there. This is the best site we have, that is abdomen is the best site. Second is site at the outer lateral anterior thigh part, that you use, never go inside, it is outer lateral part. Then the third site is outer side of your upper arm. So that, but it is very inconvenient to inject yourself from for the upper arm, and there are more chances of getting intramuscular injections. Sometimes you give injection and there is some clot, some blood comes out. So never have any doubt in that. Sometimes have any panic for that blood coming out. It only indicates that some amount of insulin has gone directly into the blood. So you have to check your blood sugars values regularly, more frequently, because there can be some chances of hypoglycemia. You have to be more disciplined with the diet, or sometimes you will have to have 1 or 2 fruit in between the meals. So this is only the answer. Or you have to change the site of insulin injection, and you have to change the needle also. So with these words, I stop here, and I expect there should be some questions from my audience. So I welcome all the questions. I thanks you all for the patience hearing. Stay safe. COVID is in rampant mood. So beware of COVID and take care of yourself and your family.
Thank you so much, doctor, for all the information. इतने basic details होते हैं जो हम miss कर जाते हैं, or we do not know, we are not aware of. आपने भी explain किए. Any question anybody would want to ask? Anything, any question, any doubt? आप अपने आप को unmute करके पूछ सकते हैं. Otherwise आप chat box पे भी अपने questions डाल सकते हैं. Any questions for doctor? There's one question in the chat section, doctor. It is, while traveling, how can we carry insulin?
Yes, I have shown you a box that is having that was there in the picture. That is the box you can get from the chemist. ये एक बॉक्स होता है जिसमें ना जेल टाइप ऑफ आइस होती है, जिसको आप फ्रिज में अगर रख देते हो तो वो आइस की तरह थिक हो जाता है, एंड दैट रिमेन्स इन द फॉर 12 आवर्स. दैट कैन गिव यू ए कूलेंट फॉर्मेट, एंड दैट विद उसी बॉक्स में आप इंसुलिन रखिए. डायरेक्टली उसके ऊपर नहीं रखना, इंसुलिन आप किसी भी कंटेनर में रखिए, लेकिन उसी के अंदर रख लीजिए. तो विद दैट यू कैन कैरी इट फॉर 12 आवर्स. After 12 hours you can keep that gel again into the fridge, make it again in ice thickened, and that can be used for the further traveling.
There's one more question, doctor. Any specific recommendations for diabetic patients in COVID time?
Yes. Remember that COVID can lead to increased incidence, increased mortality, increased grading of COVID from moving from mild, moderate to severe COVID. It's a very it's like a very dangerous relationship of diabetes with COVID. And Importantly, uncontrolled diabetes is a big factor for COVID. So diabetic patients, they are more prone for COVID, but uncontrolled diabetes is a really big thing for COVID. They require more of ventilation, more of high flow oxygenation, more of ICU admissions, and a more complicated stay is there in uncontrolled glycemia in diabetic patients. Now, one thing most important is, you during these days when COVID is rampant, you have to control your blood sugars. It should be absolutely nicely controlled. Whether you use telecommunication, remain in contact with your doctor, or with this Xyla app. Xyla people, they are doing very good job in these times, when they will tell you that they can take care of all your issues related to diet, related to your exercise, related to your medications, and they are basically bridge between doctor and the patient. So they are a very excellent tool. They can be a great help to you, so use them. Try to control your blood sugar as better as best you can possible in these days.
There's one more question, doctor. Is there any change in absorption time if a patient
Yes,
change site of
definitely.
injection?
Yes, definitely. If you abdomen is the best site. If suppose you are using regular insulin on abdomen, you have to inject say 30 minutes before the meal. But if you are using this molecule, this is on the thigh. Regular insulin doesn't has much of changes, but if you are using for longer acting insulin, then it is onset of action and duration of action is much more prolonged if you use it on the thigh side. So change of absorb time is also dependent upon the site of injection which you are using.
Uh, since we are running a little short in time, thank you so much, doctor. Anything that you would want to, in general, tell the patients over here?
Yes, even if you have lockdown or not able to go out, keep yourself active. Don't keep on don't increase your sedentarism. Keep yourself active. Keep on doing short exercises, or climbing of stairs, upper limb exercise, lower limb exercises, or move around in the house or the room or terrace. Keep on remain active, physically active, and never let your blood sugars go up. And also take care of your diets.
Thank you so much, doctor, for all the information and for explaining it so well and helping us out over here. I'm sure सबको बेसिक अपने मेडिसिन एंड इंसुलिन को कैसे लेना है, करेक्टली लेना है, जो क्वेश्चंस होते हैं, छोटे छोटे डाउट्स होते हैं जो वो पूछना भूल जाते हैं या ध्यान में नहीं रहता है, वो पता चल गया होगा. थैंक यू सो मच एवरीबडी फॉर ज्वाइनिंग इन द सेशन. इन केस अगर आप में से किसी को कोई भी और क्वेश्चन हो या कोई क्वेरी हो जो आप अभी नहीं पूछ पाए हैं या आपको बाद में ध्यान आए, यू कैन डेफिनेटली आस्क इट ऑन द Xyla ऐप एंड हम डॉक्टर से शेयर कर देंगे आपकी क्वेरीज. एंड एज डॉक्टर सेड, हम एक एक्सटेंडेड टीम है, डॉक्टर एंड आपके बीच में एक ब्रिज की तरह काम करेंगे. तो वी कंटिन्यू डूइंग दैट एंड हेल्प यू इन केस ऑफ एनी डाउट्स, एनी क्वेरीज. सो आई होप you'll all be very good with taking care of your insulin and your medicines on time now. And thank you so much, doctor, for all the time and for such amazing information. I hope you all have a great evening and a safe time during this COVID. Thank you so much.